listeners. My name is Olga Lukina. I'm a board-certified behavior analyst and certified occupational therapist. The main goal of this podcast is to inform families who raise children with autism, as well as specialists, teachers, other interested listeners, about the difficulties and scientifically approved therapies and methods to improve the quality of life of people with autism. So today we will have a conversation on the topic feeding problems in children with autism and effective treatment with the board-certified behavior analyst Covall. Welcome to episode 7. Hello, Carly. Thank you for attending my podcast. And let's discuss today's topic, feeding problems in children with autism and effective treatment. But first, introduce yourself to our listeners.
Absolutely. I'm Carly Covall. I am a BCBA over in Massachusetts. I work in a center for early learning. So I work with kids between the ages of about 18 months to 6 years old. My area of interest is feeding. I have extensive feeding experience working with kids as young as 18 months all the way up to about 22 years old. I'm also at Simmons University getting my PhD in behavior analysis.
Oh, great. Mm-hmm. It's great that you have an opportunity to get PhD in behavior analysis.
I am a true behavior nerd, so I really followed it through.
That's great, yeah. So let's speak a little bit more about the feeding problems and children with autism. As we know, children with autism are 5 times more likely than their peers to develop a feeding problem. So what kind of feeding problems can children with autism face in general?
Yeah, so feeding problem behaviors comprise a continuum from picky eaters to full-on refusal. And the effects of those feeding problems can range from mild, so just missing a meal, to more severe, which could be tube dependency or failure to thrive. Regardless of where the problem behavior falls on that continuum, it's important to consider the social and medical implications that they have on your child. So, given the breadth of potential feeding problems, I'm going to focus kind of on the most common feeding problems that families may see at home. Overall, these problems tend to fall into 4 main categories or areas. The first one being food selectivity or texture problems. Many children with autism spectrum disorder, ASD, are very picky eaters. They may eat only a few foods or specific foods. They may also object to the color, texture, or smell of certain foods. And children with food selectivity may refuse to eat anything other than those very selective foods. Our second main area is that difficulty sitting at the table during a meal. This is common in children with ASD. Other children with and without ASD may have difficulty being seated at a table in general. But when we see it in a meal, this could be a child that is coming to the table, taking a piece of food and darting away, only to come back minutes later and take another bite. Some children with ASD also graze, where they kind of eat little meals all throughout the day. And then when it's time for a meal to happen, they're not hungry, so they're not motivated to sit and expand their food choices. Our third main area is eating too quickly. So some children may stuff large amounts of food in their mouth before swallowing the previous bite. Others may clear their plate within a few minutes of getting to the table. And our fourth most common area of feeding problems is overeating. Some children with ASD consume large portions during meals and may even take food from someone else's plate. Others may take food from the refrigerator or the pantry without permission. It's really important in those cases to control food intake, but in doing that, it may cause conflict between a parent and a child and result in some other challenging behaviors. So those are sort of the 4 most common areas that I have certainly seen in my practice of areas of concerns that parents have.
Mm-hmm. Okay. And if we speak about the consequences of feeding problems, so what kind of gastrointestinal problems can appear in children with autism, like reflux or abdominal pain?
Yeah. So I'm not a medical professional, but from what I gleaned from the literature, the most common gastrointestinal or GI complaints in ASD are constipation, diarrhea, and ga- GERD, which is essentially heartburn or reflux. Um, as a clinician, I have to stress the importance of ruling out an underlying medical condition that may be perpetuating any child's feeding difficulties prior to initiating a feeding intervention. Um, there are some common medical concerns, like we talked about. And it's also important to consider allergies or even food intolerances. Um, Other sort of concerns that we see in feeding are oral motor issues, so having difficulty chewing or swallowing, and that can impede a child's ability to safely consume foods.
Okay. Yeah. So if we speak about the first type of feeding problems you named, that was food selectivity. So
Mhm.
how can parents understand if there is a problem of food selectivity, and when do we need to be worried about how selective the food choices are, and when to worry about the eating habits?
Yeah, so there's a lot to unpack there. Um, in order to understand if there's a problem of food selectivity, I need to sort of put something in perspective. In many ways, we all have some slight selective feeding. For example, I don't like mushrooms, like at all. I don't like the taste, I don't like the texture, so I don't eat them. If they're incorporated into a dish with other things, I may eat around them or see if there's another option that's available. If someone gives me just a mushroom, I'll probably say no and maybe see if there's something else still. And if you try to make me eat the mushroom, I'll probably engage in a host of fun and festive behaviors to get out of that situation. Um, I also demonstrate some mild selectivity based on brands I'm really loyal to. I have this one brand of granola that I really like, and I prefer to eat it over other types. I'm saying sort of all this personal information to say and stress that selective feeding behaviors or problems are something that I think most people demonstrate and are usually just associated with individual preference. Food selectivity is considered a problem when it poses a risk to your child's health and their development. When in doubt, talk to your child's medical professional. If you have concerns about the amount, variety, or the manner in which your child eats food, contact a medical professional. Um, as a rule of thumb, if your child eats less than 5 foods and is missing a critical food group like protein and vegetables, contact a medical professional.
Okay. So if he eats less than 5 foods, or is only like one sort of the product type, we can think about the food selectivity and must go to the doctor and see what happens. So what causes food selectivity in children with autism?
That is a great question. So, to my knowledge, there's no definitive or singular cause of food selectivity, but there is certainly a sensory component that may contribute to a child, particularly on the autism spectrum, to reject certain foods, therefore limiting the variety of food items in their diet. It could be an aversiveness of the smell, the texture, color, or even the temperature of some foods that contribute to that food selectivity. Other research has shown that child feeding problems don't develop due to one specific condition or event, but more as a result of a combination of medical conditions, anatomical abnormalities, oral motor skill deficits, and behavioral factors. Um, Medical conditions that produce pain or discomfort as a byproduct of eating may result in food refusal as well. For example, if a child is experiencing pain due to acid reflux or even a food allergy, they may start to refuse all foods or those specific types of foods when they're presented to avoid experiencing that pain. Children with a significant oral motor delay may not have the ability or even the stamina necessary to chew foods safely and swallow them safely. This is why getting that medical evaluation and continued consultation is so crucial when we're thinking about, is this a problem and how do we address it?
Okay, so maybe we can speak about the specialists. So what kind of specialists are in a multidisciplinary team to address feeding problems?
So there are a host of people who can be a part of a feeding team. I have extensively worked with speech and language pathologists as they are experts at oral motor abilities. Occupational therapists are also a great source of information and support and evaluation when it comes to feeding problems. A pediatrician or any sort of primary care provider will be able to give that medical consultation, as well as nutritionists. There are other really specific specialists like an ear, nose, and throat doctor or a GI doctor who may be brought onto a team if those are areas of concerns for any individual. Here that we put BCBAs are often, our behavior analyst often joins the team. And most important part of a multidisciplinary team is actually the caregivers, because they're the ones who are with their child providing meals most consistently. A lot of the research and the research that I'm really interested in is that parent mediated feeding interventions, because that's where we see the greatest change. I like to tell my families that it's only real if they see it at home too. I can show them, oh yeah, say your child ate a carrot for the first time, but being able to go home and then give their child a carrot and see them eat it can be such a rewarding and positive experience for both the child and the parent. So they're at the center of any team. There's the child themselves and then the caregivers.
But if we watch the process of specialists, who is the first one a parents need to address, like pediatrician or other specialist?
Yeah. First stop is a pediatrician. Go to your pediatrician, let them know what your concerns are. They'll be able to say if your child's underweight, and also give a referral for further evaluation to additional services.
So, and the next person, if we see the way how it happens after the pediatrician.
Oh, so from my experience, it typically goes pediatrician. If there are concerns about weight or potentially nutritional imbalances, then to a nutritionist. At the same time, a child's often given a referral for an oral motor assessment. So we also call that a swallow study. And that's typically done by speech language pathologists, as well as can also be done by an ear, nose, and throat doctor. So it depends on where the pediatrician makes the referral out to. From there, I typically see referrals go to occupational therapists to further evaluate those oral motor ability, the ability to chew, and the distribution of muscle output or effort output in chewing. And then come down to BCBA.
So just let's discuss some examples, like Cause for concern can be when a child may prefer only a specific appearance of packaging, smell, or texture of food. For example, a child prefers drinking a specific type of juice from a container with mignon packaging, and they refuse the same product with different packaging. This can lead to unwillingness to try new foods. So why does this happen?
So before we kind of get into I can get into the why it happens. When we think about how we currently diagnose ASD, one of the criteria includes restricted and repetitive patterns of behavior, interest, or activities. Under that criterion, eating the same food is just another example of restrictive and repetitive behavior. But this conceptualization of a feeding problem is not new to autism. In fact, in 1943, when Leo Kanner wrote his first initial description of autism, he observed this distinct pattern of rigid and restrictive feeding behaviors. We can therefore see food selectivity in general within this lens of resistance to change or an insistence on sameness. That may go beyond just having a preference for foods. So with that in mind, what we're talking about in this situation about selectivity based on brand is just another demonstration of this insistence on sameness and resistance to change. It could be that the rigid feeding behavior is another demonstration of that, and also maybe a demonstration of the positive pairing between that brand with a familiar face on it and some unknown brand that doesn't have that same icon that maybe that child really loves. So that's potentially why, can be why.
Yeah. And what kind of interventions can be used to manage this kind of problems?
I have some general tips and strategies that we can talk about to be used for many different forms of food selectivity. So one of the strategies in a situation like this can be to provide a child choice. You can provide your child choice between the juice without the minion and the juice and another drink, sorry. So they have their juice in one cup or the juice in the box that they don't know, but it is the juice they like, and some other drink. I strongly urge parents not to hide things from your child because that can damage trust and increase likelihood that your child will not eat things or accept things when you offer them. So when possible, enabling a child to make choices about what they want to consume, and recognize that sometimes it's about exposure. If you offer that juice without the minion on the packaging enough times with, water or something else, they may try it. Just having it available to them as something that they can choose to consume can be helpful in shaping that behavior you want to see.
So, do you mean that we can use only like a choice as a method of intervention, or there are some other things to use?
There are other things to use as general strategies. I think this is important for me to say that if a child has serious feeding issues, it's really important to seek that individualized treatment from a professional. You start with your pediatrician and go from there. What I can kind of help with is positive behavior support strategies to help potentially improve the quality of meal times with a child. And while the suggestions I provide can be helpful with certain feeding problems, seeking professional help and guidance is crucial in ensuring that these behaviors are addressed in a safe manner. Seeking guidance and support as feeding problems need to be addressed using evidence-based approaches and with ethical considerations in mind is crucial. And so I urge anyone listening to seek training and supervision from professionals with expertise in this area. So a lot of my suggestions are going to be general. In the case of brand selectivity, providing choice is one of them that I often recommend to families. And there are others that I'm happy to kind of go into more detail about.
Yeah, I think we can go into the details about the interventions and then continue speaking about the different examples.
Yeah, so some general strategies. Some of my suggestions are kind of were in reference to one of your questions about making a positive process. So maybe I could just kind of jump in there and talk through the things that you can do there. Because that, I should ask, do you have experience with feeding at all?
Some kind of shaping. Yeah, when we teach a child just to touch a food and then just to put the food to the mouth and etc., dividing to several steps and reinforce.
Yeah, so that's typically what I honestly do a lot of nowadays, is a lot of just shaping skills within a repertoire. Um, Mostly because that's the most positive way of shaping a child's food selectivity. And I feel like it's also the most well accepted by families. So maybe we could talk a bit about that.
Yeah, it can be great if you can name this kind of like methods, let's say like that methods and how they can look like. So we will discuss some examples also after that, but if you can give also a little bit more examples with these methods, it can be great. So
Yeah.
parents can hear and think, okay, I have quite similar example, and what kind of stretch this can be to use is they understand that they can't use these methods by themselves, but they are informed that these methods exist. You know what I
Okay, yeah.
mean? Mm-hmm.
Okay. So I think I got this now. So this is actually from the Ruby. A lot of these suggestions come from the Ruby is a parent training manual. It's for disruptive behaviors, and there's a supplemental section on feeding. So these are kind of like widely used strategies for parents. So when we're addressing food selectivity and that texture preference, we typically set some goal of increasing the number and maybe the range of foods that a child is willing to try. We do this by using two of the major principles in behavior analysis, shaping and positive reinforcement. With shaping, we're making those small, gradual changes in what we're asking the child to do. With reinforcement, we'll use preferred items and activities, or even maybe favorite foods to reward target feeding behaviors. So I like to start, or we should start, with first identifying something that a child really likes and that they can get as a reward for demonstrating a specific feeding behavior. If that's something that we can keep isolated so that they don't have access to it all the time, that's great. So if your child really likes the iPad, you could hold on to the iPad and keep it only for when you're working on feeding. That's great. If not, that's okay. You know, I recognize that that's not always feasible. You can also ask your child perhaps what they want to earn and have them pick something out before each meal or feeding session. But whatever feels most natural to a parent is typically what I go with. We then pick the food that the child is going to try to eat. We typically start with something that is similar to something they already eat. So for example, maybe the child already eats frosted Cheerios. Now we'll do like a honey nut Cheerio. Looks the same, comes in a similar box sometimes. It's just the taste will be slightly different. Once we have, and we call that a lateral food, and we can really get a lot of momentum of acceptance and consumption when we use those foods that are similar to foods that a child is already eating. Once we have the reward that we're going to use and the food that we're going to start with, we decide what skill our target is going to be. This could be something like they're going to cooperate with just touching the food initially, or tolerating it being on a plate in front of them. It just depends on where that child is currently. Some children see a new food on a plate and will immediately push it away. So that's where we start. Is okay, we're just going to tolerate you seeing this Honey Nut Cheerio in a bowl, maybe even on the other side of the table from you. And over time, using shaping will increase the expectation. But that is a slow and incremental process because we want the process to be so positive. So in this example of my Honey Nut Cheerio in a bowl, maybe a little bit away from the child, we'll set some sort of expectation. They'll sit there for 30 seconds with the Honey Nut Cheerio in a bowl near them, absent of, them pushing it away or having a hard time. As soon as they meet that goal, we'll give them that reward with a lot of praise. Wow, I'm so proud of you for for sitting with the Honey Nut Cheerio on the plate right there. You did such a great job. Here is whatever it is that they've picked out or you've picked out for them to earn as a reward. After a couple practices of that, we'll then increase the requirement. So now maybe the child has to touch the bowl. Nothing big, just touch the bowl. A few times of them being able to do that, absent of more challenging behavior or refusal behavior, will increase the requirement again to now you need to touch the Cheerio or the Honey Nut Cheerio with your finger or with a spoon. And slowly and gradually we shape it from touching it with a spoon, putting it on a spoon, bringing maybe the spoon to our nose to smell it, or just bringing it to our face. Then a lot of things that I see parents do and that I do as a clinician is I call it the touch, lick, kiss, bite, swallow. First you touch it, then you kiss it, then you lick it, then you bite it, and then you bite and swallow it. Slowly over the course of time. I also really encourage families to read their own child's signs. As a clinician, I do a lot of what's called assent-based instruction. So when I'm doing a feeding intervention, I ask a learner or a child, hey, do you want to do mealtime right now or do you not want to? And allow them to choose. If they choose to, awesome, we come to the table, we do a feeding session. At any point, if they no longer want to participate, they get up and leave. They say no, they push the plate away. We're done. I say, okay, we're done with this. We're all done. The reward, whatever it was, whether it's the iPad or right now I have kiddos that really like these little dolls, little figures. Mm-hmm. Those aren't available because we didn't work on the skill and we didn't meet our goal, but everything else goes back to normal. So I recommend that parents and caregivers use some level of that in their own practice times with their child. If your child is showing signs of distress or that they don't want to be a part of it, allow them to leave the table, allow them to access that escape, because feeding and eating is so crucial to our development, to our access to social interaction, and for mind and body. It's what keeps the machine running, right? So we want that experience to be as positive as possible. And so as the caregiver reading your child's signs of this may not be a fun experience for them is so crucial, and honoring those signs as much as possible. I kind of took myself off topic there, sorry.
Yeah, that's okay. It's about the intervention. Yes, yes. We talked about the shaping. What do you think about the extinction, about the procedures when the spoon is close to the mouth and is not taken away till the child eats that?
Escape extinction is a well-researched, evidence-based practice for feeding interventions. As a clinician, I am able to make meaningful outcomes using less restrictive interventions. So I typically don't incorporate it unless I need to into the interventions that I do with my clients. I've also found that it's quite difficult for parents to do, and to do safely. So it's not something I recommend to parents.
Yeah, I asked because I think it's sometimes like a little bit typical stuff in the kindergartens when a teacher can use, like, of course, not knowing about the extinction principles, but using this, yes, just holding this and saying, you need to eat. Another way, you can't, like, have your time, like have reinforcement. So this kind of things, I think it's important to talk about that.
Yeah. So escape extinction can look like holding a spoon or a utensil to a child's mouth. It also may be leaving a plate out, like the food, leaving a plate on the table and having that child sit there with the plate um, for an extended period of time. Well, anytime we use an extinction procedure, we run the risk of seeing emotional responding. So, seeing signs of distress. Um, we could also see loss of skills in some ways. Now, that child may not eat foods that they were once eating. They may engage in escape behaviors like running away and hiding when it's time for a meal, hiding food in places that they think people won't look, like trash cans, under sofas. I've heard and seen some interesting escape behaviors. Um, and ultimately, what we're doing is pairing this, or making something that may already be difficult for this child even more difficult. If sitting at a table is hard, having them sit with a food that they may not like or may really dislike, and maybe also not even hungry for at that time, um, we're inadvertently potentially punishing some of their communication, them telling us that I don't want this, no, um, or that I want something else, whatever that looks like for a given child. Um, and we're also pairing this potentially aversive situation with meal times. I think oftentimes I use this language of, how big is the problem? Are you worried that your child's skipping one meal, or that they're not eating enough per day? I think sometimes we get really focused on our adult timetables and schedules that we don't necessarily consider that may not be the same for a child. Um, Other things like meal size or serving size is something that I talk about a lot with families of a 4-year-old cannot eat as much as an adult and should not be served as much as an adult um, because their stomachs are smaller. They are smaller beings. So when we are now creating this situation where we're in a power struggle of you need to eat this food, we are damaging trust between ourselves and that child. And we're also maybe setting expectations that that child's not ready to meet, whatever those may be for a given child.
Thank you, Carly. Yeah.
How did that sound? That sound okay?
Yeah, that's okay.
Okay.
Thank you so much. Yeah. So sometimes parents complain that they can face a lot of problem behaviors during eating. For example, like running away, screaming, throwing the dish from the table. How can we discover why this behavior appears during eating episodes? In other words, define the function of behavior, just in general.
Yeah. When we're talking about the function of a problem behavior, we're touching on what we think the person engaging in challenging behavior is trying to communicate to us. Oftentimes, this is because they don't have the words to expressly tell us that they want to be all done with something like a meal, or that they don't like something, or maybe that they do want something. It may also be the case that they're trying to tell us and we may not be listening or honoring those requests. So, on a surface level, when we talk about feeding problems, we could say that these challenging mealtime behaviors may be trying to communicate to us that the child is trying to escape from something that's not desired or preferred. That may be sitting at the table in general, or it may be about the foods that we're presenting. We can see these behaviors as a method of control and also a way of expressing that whatever is going on in the current environment is not what that child wants. It could be that the food itself or the environment in which the foods are presented are that signal. It may also be something about the smells um, or some other factors. Maybe the TV's on in the other room. It's hard to say. Um, in When we're thinking about these escape behaviors, it could be that in the past, these behaviors have resulted in that undesirable event, whatever it may be, whether it be the food or the environment, to be removed. So when this happens, it's also possible that we've introduced some preferred outcomes. Um, I give you this plate of food you don't like, you push it away and run away. I remove the plate and put something else out that you do like. Well, now we've taught, okay, when a plate of food that when the child doesn't like is presented, that child has learned I can just leave and can come back to something else that I do like. So it's therefore possible that forms of attention or access to different food or a different activity could also be a part of the function of a given feeding problem. We could then say that it's possible that these behaviors may function as both a method of escaping from something undesirable to something preferred. Um, if someone thinks that their child's challenging mealtime behaviors may be tied to the desire to control some aspect of mealtime, this is where I come in and say I strongly suggest providing as many opportunities for choice within the mealtime as possible. Choice is a powerful tool in getting someone's motivation, their buy-in, and that they're feeling like have a bit more control over the situation.
And if we speak about the second type of feeding problem, that is sitting at the table, you mentioned before, what are possible strategies to shape the behavior of staying at the table longer than taking one bite and running away during the mealtime?
So when we're looking at increasing that time sitting at the table, there are two strategies that we can use. The first one is controlling the environment. So limiting distractions or things that may be competing with the child's motivation to participate in the meal is a part of controlling the environment. We also can set a rule that all food must be eaten at the table. And it's super important that all adults also model that if that's a rule that you set. So everyone eats at the table. And not allowing food to be taken away from the table. The child should also be able to leave the table whenever they like, but must sit down to eat additional food. You can also set a rule about the number of times that they're allowed to leave the table before the meal is done. This should be initially something you feel that the child is able to do and is also manageable for you. And then over time, gradually decrease the number of opportunities. So let's say you set a rule, everyone eats at the table. For right now, the child is allowed to leave the table 5 times before the meal is considered done. After they come and go 5 times, you'll say, okay, time to clean up and clean up the meal as you normally would. Once you see that the child is only leaving the table 5 times, we can then decrease it to 4 times and so on and so forth from there. So that's one strategy. Our second strategy is to gradually increase the amount of time the child remains in the seat during the meal by using a timer. So you could set a rule initially or a goal of something like the child sits at the table for 30 seconds before they're done. They need to remain at the table until that alarm or bell goes off to earn a reward, I should say. In all of these strategies, having something to reinforce your child, a reward for doing the things that you want to see them do is so crucial. So in this case of sitting at the table, they sit at the table for 30 seconds, they get that reward, whether that's a different food, an additional activity or item, whatever it is for your child. If you're doing the increasing in seat by time, if your child gets up before the bell goes off, they just don't get that reward. And letting them know that that's what's going on. Like, hey, like, remember, you need to sit for 30 seconds to get the iPad, whatever it may be. Another really common strategy or a good general strategy is using first then language. First sit until the timer, then get iPad. Using that really clear, concise language is something that allows a child to know what the expectation is and what they need to do to get the thing they want, and avoiding telling them the things not to do, so that
So like be clear in your instructions, yeah?
Yeah, thank you.
Yeah.
Getting tripped up in the language there. But yeah, being super clear about the expectations, about what the expectations and what the rules are of whatever it is you're trying to work on. It is so crucial. And first then language is always a good one.
Yeah, so one more example. A child may eat only clear products like porridge, but he refuses to eat porridge with berries or raisins inside. a child refuses to eat different foods together, like mixing potatoes with meats and salads. So what kind of interventions can be used in this case?
That is a great question. So,
And is it important to eat mixed products?
what I have found in the literature about mixed foods is if it's possible to split the foods and present them as separate and allow the child to mix them themselves, um, can be very helpful in that process, and also making it an interactive process. This is not coming so much from behavior analytic research, but more from occupational therapy, actually, because altering that one sensory aspect of a meal at a time is crucial. So if you've introduced porridge and you want to add berries to it, allowing the child to do it themselves and limit or decide the amount that they want to do allows them to have control over that. It's the same idea of using separated plates, plates that have divisions in them, so that each food group is separated and then they can mix it together as they like. It is still a process of shaping. So maybe you present the porridge with some berries. You say, okay, first put one berry in, then get and eat, then get iPad. So they put one berry in, they take that bite, awesome, they get the iPad, and slowly shaping it up so it becomes more mixed in. I personally like to put the control on the child, so they can decide, how much they want to put in, because it can be, if we're thinking about the level of mixed things, rice with a bunch of different vegetables and proteins in there, it can often look like we're hiding something in it. So allowing them to have that control, and using their momentum is crucial.
Yeah, a little silly joke from me. So in the end, everything will be mixed in the stomach. So no matter how visual can it look like, yes, if a child doesn't like that. So anyway, yes,
Yeah,
the
absolutely.
finish line is the same. So I also wanted to ask an additional question about the third and the fourth type of eating problem that you mentioned, quickly eating and overeating. Maybe you can also describe some possible interventions in these cases.
Yeah. So for eating too quickly, we can use a combination of prevention strategies and teaching new skills for this particular issue. The common strategy I have seen and used to teach children to eat slower is to put their fork or spoon, whatever utensil they're using, down between each bite. So they stab the food, with their fork, they bring it to their mouth, they put the fork down, they chew and swallow, maybe take a sip of water before resuming that process. So this may look like the caregiver prompting them to put the utensil down, praising and rewarding them for cooperating with that prompt, maybe using some sort of visual to signal how long they need to wait. So counting on your fingers from 5 down to 0, or from 0 up to 5, as well as counting it out loud before they have to take the next bite. It may also be helpful initially to keep the plate just out of reach when they're taking that kind of 5-count break in between bites, and also limiting the amount of food initially available on the plate. You can always add more. It's much harder to take it away when someone's trying to eat. So start with small amounts, and you can put more on the plate as they slow their eating.
Yeah, and what are possible interventions in overeating?
When we're thinking about overeating, we can there are some sort of general strategies, or often we call them prevention strategies, that we can use. So it is helpful to provide healthier food options and limit the availability of high fat and calorie foods and drinks in the house. Some foods are high in calories, but don't necessarily give that lasting feeling of being full. These kind of foods, like all junk foods, um, and most starches, should therefore be minimized. We want to provide these kids who are overeating with small portions of highly filling foods. Those are foods that are whole grain, like oatmeal, or whole grain rice or bread. Um, some leaner meats like chicken and turkey um, during these meals. So we start by providing these smaller portion size meals of highly caloric or highly filling foods on a regular mealtime schedule. People who overeat tend to skip meals and will usually seek high calorie, low nutrition snack food between those skip meals and their next meal. It's important for a child to get a full and complete breakfast, lunch, and dinner, with those snacks in between being small, ideally healthy snacks to tide them over until their next meal. Also, with overeating, promoting healthy lifestyle of exercise and movement is so crucial. It's something that can be done together with parent and child as a fun activity, but also means to burn off some of those calories, so that when we present those meals of highly filling foods, they're able to eat them. And that's kind of all of the prevention strategies we sort of have for overeating. If someone's concerned about their child eating too much and potentially gaining some weight, talk to your child's pediatrician. They'll be able to give further guidance on nutritional directions to go, as well as if there are concerns about your child's weight.
Mhm. Thank you, Carly. Do you have some more additional words to our parents who are children with autism?
Yeah, so there are just some general strategies I have for making the eating time or meal times a positive process. So that first one is setting mealtime routine. Um, if your child's a grazer, they may not be hungry at meals and may not be open to trying new foods. If they get to pick what they eat at any time, they have no reason to come sit at the table. So establishing both a time and place for eating is crucial. We can give a mixture of meals and snacks every day at the same time, with ideally the main meals being about 4 to 5 hours apart. I recommend limiting snacks to one in the morning and one in the afternoon, maybe one in the evening if that works for your household. Um, this increases the chances they'll be hungry at those meal times. We can provide snacks that are healthy, low calorie, to ensure that they're hungry at those meals as well. Typically, I use snack times as a time to practice mealtime behaviors, whatever those may be, whether it is trying a new food, sitting for longer periods of time. And I recommend that one of those snack times be what I call a practice time, because meal times themselves with a full family can be really hectic potentially and maybe stressful. So using these snack times as an opportunity to practice these skills outside of that meal time can be helpful for both caregiver and child. Um, I also recommend setting a time limit on snacks and meals. So maybe 15 minutes for snacks, 30 minutes for meals. This will help the child learn that meals and snacks are a part of the schedule and not something that happen all day. If you do set a time limit at the end of that time, let them know that the meal's over. You may want to come up with another signal for it, whether it's a timer, flicking the lights on and off, clapping your hands and saying, okay, we're done, and then cleaning up the table. If your child cooperates with prompts to assist you with the cleanup, include them in that process. I also recommend ending a meal on something positive and related to your goal. With a lot of my clients, I do a debrief time with those that can to say, hey, like, what do you think went well? What are you proud of? And also giving them that feedback if they're someone who can engage in that sort of conversation with you. Otherwise, just ending the meal and being like, giving your child that really, really enthusiastic, specific, powerful praise of, I'm so proud of you for sitting here during your stack time, or thank you for helping me clean up. That was amazing. Or you're so brave for trying something you don't necessarily eat. I know sometimes we feel our words may go unheard, but it's the way that we say it that often has the most value. Kids know when we're proud of them, is my personal philosophy. And this kind of ties into the whole strategy of making meal times positive in general. We want to avoid power struggles as much as we can. When it's time for a snack or a meal, present the food as you normally would and try to avoid reminding them to eat or to hurry up, but instead giving a lot of praise, and even enjoying the food with them if that's possible. Sometimes if we're introducing foods they don't like, we have to do a little bit of fun with food and make smiley faces on food with ketchup, or make the carrots talk to each other. Whatever your child likes, making it a positive process is really important. I said this before and I'll say it again. We don't hide food in our kids' food. It damages trust and increases the likelihood that your child will not eat the things that you offer. And in terms of, on the positive, celebrate and praise. It's important for them to know how proud you are of them being flexible and agreeing to this. And we need to recognize that no matter if it's a big win or a small win, it's still a win, and celebrate those with them.
Thank you so much, Carly. This is a difficult topic to speak, I think. So thank you for sharing your knowledge and experience in this field of problems. Thank you so much.
Well, thank you so much. And I hope that this was helpful.